My name is Leanne Larange. For those who don't know me, I am the manager of policy and practice here at the College of Physiotherapists of Alberta, and it is my great pleasure to join you today as host of this webinar session. We have an excellent presentation ready for you here today, and I'm very optimistic that it's going to provide a lot of valuable information to our registrants. As we get ready to begin, I would like to begin by giving a land acknowledgement. My name is Leanne Larange, as I said, and I'm speaking to you today from Edmonton. And I'd like to begin by acknowledging that the College of Physiotherapists of Alberta's offices are located on Treaty 6 territory and the lands of the Métis Nation of Alberta's Region Number 4, which has been and continues to be the home of many Indigenous peoples since time immemorial. The College of Physiotherapists of Alberta recognizes that Indigenous peoples have been helping many to live healthy lives on this land since long before settlers arrived. And we commit ourselves to helping move people forward in their journey towards a good life, and doing so in a way that follows the spirit and intent of treaty, that of peace, friendship, and understanding. We know that people from across Alberta and beyond are joining us today, and we encourage you to take a few moments to learn more about the lands, peoples, and treaties with which you may be in relationship. And now it's my great pleasure to introduce today's speakers. Ryan McGrath is a physiotherapist and recently received his PhD from Charles Sturt University and is an academic at the University of Melbourne. Ryan's PhD explores physiotherapist experience with clients experiencing psychological and suicidal distress. He has volunteered as a telephone crisis supporter and is currently completing a graduate diploma in psychology. And Sophie Shephard is an Australia Physiotherapy Association titled pain physiotherapist. She's a committee member of the New South Wales branch of the APA Pain Group and is director of VIV Pain and Fatigue. She has extensive clinical experience working with clients experiencing distress and suicidal distress in association with complex health conditions and has collaborated with Ryan on several publications and projects related to these issues in physiotherapy practice. She's also currently a PhD candidate at Charles Sturt University, exploring issues of rural health inequity and social justice in pain management. I will remind all audience members to please go ahead and type in questions at any time during the session. And I will also remind you that the session is being recorded, and we will have the recording available for you to view after about 2 business days to get that up and on the website, but then it will be available to view if you need to leave at any time or wish to revisit the content later. And with that, I will turn the presentation over to Ryan and Sophie. Thanks very much.
Just checking you've got slides up looking good to go, Ryan, on your end. I've got everything good to go.
Are we screen sharing? I don't think I see it yet.
Oh, is anyone else getting it? It was sharing, but Leanne, can you just confirm if anything's coming through your end?
No, unfortunately, I'm not seeing that screen share right now, Sophie.
Oh, sorry, it must have switched off when we came from the backstage. Just give me 1 sec.
Sure.
Yeah. Try that.
There we go.
There we go.
So thank you, Leanne, for the introduction. Sophie, in my presentation today, Mobilizing the Physiotherapy Workforce for Suicide Prevention, will cover a fair bit of ground. For some of you here today, the content may not be that unfamiliar. However, based on my PhD research and research in this area, a lot of physiotherapists find supporting people experiencing distress and suicidal distress quite challenging. So we might skip the introductions because Leanne did quite a great job, but really the crux of things, I'm an Australian physio, really passionate about suicide prevention. I've now just finished my grad dip in psychology as well, and I'm really interested in psychologically informed physiotherapy practice more broadly.
Absolutely, and similar to Ryan, I tend to keep myself busy and wear a few hats, and am generally working as a clinician researcher, interested in a fairly wide range of areas. That we're looking at that list of areas of interest seem pretty diverse, but all kind of relate to my experience of clinical practice and working in sort of complex pain and fatigue conditions. And before we launch into, I'd just like to acknowledge that I live and work on Wiradjuri land in Wagga Wagga, New South Wales, and just want to pay my respects to the traditional owners of our land here too.
Right, so before we get started, let's talk about what we already know about physiotherapy practice and suicidal distress. The following presentation discusses psychological distress, trauma, and suicide in the context of physiotherapy practice. The content has been included for the purpose of improving your recognition of suicidal distress in others. Please remember that each suicide-related statistic represents a person with a family and community grieving for their loss. For anyone here today who has been bereaved by suicide, we extend our deepest condolences. For anyone here who may be currently experiencing thoughts of suicide, we encourage you to reach out to someone, for example, a trusted family member, friend, your GP, or another local service. You are not alone, and you do not have to be alone. So, as part of my PhD, I completed a qualitative research study that looked at physiotherapists' experiences with clients experiencing psychological stress. An overarching theme was that encounters were perceived to be common and varied. The forms of distress included physical and non-physical related distress, grief, loss, trauma-related distress, and in some cases, suicidal distress. Suicidal distress, while reported by participants to be less common than other forms of distress, were described as extremely confronting, challenging clinical situations in which physiotherapists felt that they had not been well trained to deal with. Experiences range from disclosures of ideations with no plans, all the way to a physiotherapist reporting being the last contact before a patient's death by suicide. As part of my PhD, I also conducted a survey of about 340 Australian physios. Of respondents, just over half of physiotherapists reported having received a disclosure of thoughts of suicide yearly or more frequently. In addition, almost half of physiotherapists reported receiving disclosure of a plan for suicide at least once in their career. This is not surprising given the association between suicidal distress and poor physical health. The survey also revealed that physiotherapists working in some areas were much more likely to report having received a disclosure of a plan for suicide than others. Of areas of practice, pain was by far the highest, with almost all respondents reporting a disclosure of a suicidal plan at least once in their career. So that was around 90%. And if we compare it to another area of practice like pediatrics, that's at around 20% of physios in that area having received a plan for suicide once in their career. Before continuing, I just wanted to flag the relationship between distress and suicidal thoughts and behaviours. Suicidal thoughts and behaviours can be conceptualised as an unhelpful coping mechanism to deal with distress. While not everyone experiencing severe distress will also experience suicidal thoughts and behaviours, as one's ability to cope decreases, the more likely a person is to consider suicide. Suicidal distress may also be associated with a triggering negative event or a series of triggering negative events.
So it's important to acknowledge here that most patients that we're going to see in clinical practice might not be at the extreme end of the distress spectrum, and they may not ever attempt or die by suicide. But the risks of missing those rare cases could clearly be catastrophic. But we still have a responsibility to screen for and refer on where needed. And I think the closest analogy we have as physios is thinking about the case of cauda equina. So we acknowledge that as physiotherapists, we are not the professionals who are responsible for treating cauda equina, nor are we even responsible for fully assessing cauda equina. But we acknowledge that in the rare case that cauda equina is present, that person urgently needs referral and connecting with additional support and services so that they can be appropriately assessed and cared for. And even though that risk is very, very low, we've all had it absolutely ingrained into us from our undergraduate training that our red flag screening, our cauda equina signs are something that we need to be asking every single patient with acute low back pain. So if we kind of look to the parallels with suicide prevention, you know, we don't really see suicide prevention as any different to that, really. And I think as physios, we're also we're more likely to play more of a role in helping distress and mental health than we realize, even though we're not delivering psychological treatment. So most of the patients we see will be in varying levels of distress. They might potentially be sitting in that stage of having vague suicidal ideation, but no firm plan. There was one meta-analysis by Stubbs in which it was found that almost 30% of people with pain had a death wish. So if we consider what that death wish likely represents, we can really appreciate that it represents a real lack of hope or optimism for the future. And even if they're not high risk for suicide, what implications does that sort of feeling have for us in our clinic, on their likelihood of being able to properly engage in treatment, or their capacity to take on new information or make positive behavioural change? We know from the research that long-term prognosis and recovery is really strongly mediated by patient expectation and their beliefs. Like, we talk about things like catastrophization, feelings of hopelessness or pessimism. So, these are also very clinically relevant to us as well, beyond just mental well-being. But we also need to not underestimate our role in this space in supporting clients to access the support that they need, and making sure that we can create a space where patients can feel listened to and supported, and really prioritising that relationship so that we can help connect people onwards and support them through these feelings. It is just so important. And a lot of what we do actually has quite an indirect effect on mental health, even when we aren't delivering psychological treatment. And really, we can't talk about suicide awareness and prevention without also discussing trauma in the context of physio practice. So when we're talking about trauma, what we're talking about is a psychological, emotional response to an event or an experience that's deeply distressing or disturbing. Trauma is relevant for every single physio for several reasons. So at a broad level, trauma exposure in both childhood and adulthood has been shown to be associated with poorer health and increased risk of mental health conditions, as well as pain. And for those with pain, a history of traumatic event exposure, or PTSD, has also been associated with increased pain intensity, disability, and poorer outcomes. We don't really know why trauma and adverse health outcomes are related, but there have been some neurobiological mechanisms that have sort of been identified. Delving into that is really, really interesting, but also needs so much more time than we have today. But in the context of this presentation, it's really about understanding and recognizing that we need to be aware of trauma, because PTSD and trauma exposure are both known risk factors for suicide attempts. And it's also really important because trauma is a much more prevalent issue than many might think. Now, these are Australian stats, but based on Australian statistics, up to 75% of Australians have experienced at least one traumatic event in their life. And based on the stats we have, just shy of 70% of young people will be exposed to at least one traumatic event or potentially traumatic event by age of 17. And 12% of Australians will be diagnosed with PTSD in their life. The statistics seems to be pretty consistent across countries, particularly between Canada and Australia. So it's clear here that there is a distinction between exposure to potentially traumatic events and a diagnosis of PTSD, and not everyone who has been exposed to a potentially traumatic event will develop PTSD. But it's just important to note that. And we also can't ignore the social determinants of health and intersectionality when we're having these conversations, because we also know that there are certain groups that may be at much higher risk. So, for example, those who experience homelessness or have been in foster care or juvenile detention, refugees, people experiencing family violence, LGBTQI plus communities, Aboriginal and Torres Strait Islander, in our case, and I'm sure that it would be similar for your Indigenous populations as well, and as well as certain occupations, so emergency services and defence. And it's really important to note that trauma is important to understand and recognise, because it does pose the risk of adverse health outcomes, as well as increased risk of suicide prevention, the increased risk of distress and suicide. So while we're here to talk about suicide prevention, trauma-informed care is kind of a foundational concept underpinning everything we do. And to be really clear for those of you that aren't familiar with the idea of trauma-informed care, it isn't about the treatment of trauma. It isn't even about asking people whether they've experienced trauma. It's just the recognition that because trauma is so prevalent in society and it could be affecting anyone that we see, as health professionals, we have an obligation to make sure that we're not unintentionally re-traumatizing people seeking care, creating those safe spaces and being aware that many aspects involved in medical encounters can be potential triggers for people who've experienced trauma in the past. And when we consider physio specifically, a large part of our practice often involves things like physical touch for assessment and treatment, asking clients to disrobe. And if you're working in more niche areas of practice like women's or men's health, you may even be doing things like conducting internal examinations. I'm not sure if that's something that's also consistent in Canada. That may be more Australia specific, but that's something that, in our setting is something that some physios do depending on their level of training. But all of these things make it obvious that we need to be aware and acknowledge the risk of unintentionally causing distress. So trauma-informed care is really critical for making sure that as a foundational step, we're doing no harm, we're maximising autonomy and helping to reduce distress. All of this talk about suicide prevention and, sort of helping to navigate distress in the clinic really doesn't mean much if we're directly causing harm as a starting point. So that sort of will thread through everything we talk about, and you'll hear some of these principles echoed as we continue progressing throughout the presentation. And I'm going to briefly rush through this just because it's relevant to what we're talking about, and I think sheds a bit of light on some of the patterns we might see in clinic. So the window of tolerance is a model that is actually drawn from trauma-informed care, and I think it provides a bit of a different perspective or insight into what we might see in clinic. And so to explain this as simply and quickly as I can, every person has a window of tolerance, and really this is just an ideal zone in which we can engage with the world, we can be present, we can problem solve, we can take on new information and just generally regulate emotional responses. And there can be situational factors, stress or other triggers that push us out of that window, either into more of a hyperarousal state or a hypoarousal state. Now, what that kind of looks like, typically it can vary, but hyperarousal is typically characterized by someone appearing quite elevated, maybe more reactive or hypervigilant, and what we might describe as emotional flooding. So people will often feel really angry or fearful or anxious. They might experience intrusive imagery or flashbacks, maybe act impulsively or show high-risk behaviours. But conversely, people who enter that hypoarousal state might present more with flattened affect. They might describe feeling numb or empty. Sometimes people can experience cognitive dissociation and have trouble thinking or processing information, or might describe feelings of helplessness or hopelessness. And for people who have experienced trauma in the past, that window can shrink, meaning that it's really difficult to stay within that ideal space, and it makes it really hard for people to regulate. And this is really relevant for us in the clinic because we see these patterns in the clinic when we work with people who are experiencing pain or other health conditions. And we can think about suicide or suicidal ideation as being kind of at the extreme end of the distress spectrum, as Ryan mentioned before, and suicidal thoughts, planning and self-harm can occur at both ends of that spectrum. So it's not necessarily the typical sort of presentation we might, the stereotype we conjure up when we think about suicide, where we might see someone as appearing very overtly depressed or flat. It can equally happen when people are maybe presenting more in that hyperarousal state. So actually recognizing this can sometimes be useful to clue us in that somebody might be experiencing greater levels of distress, and using that as a way of helping us to think about the ways in which we might be able to support them within our scope of practice. And the power threat meaning framework I'm going to mention very briefly, but it's basically a framework that's quite relevant to this discussion, and it's coherent with trauma-informed approaches. Importantly, this framework is non-diagnostic, so it really sees distress as a normal reaction to abnormal circumstances. So effectively what we're doing when we use this framework is, rather than labeling or categorizing someone or identifying mental health conditions, effectively asking what's wrong with you, the power threat meaning framework really seeks to understand someone's experience, asking things like, what has happened to you? How did it affect you? What sense did you make of it? What did you have to do to survive, and what are your strengths? So it's really not concerned about those diagnostic labels and sort of categorizing people based on pathology. And just before I hand back over to Ryan, I'm going to just touch on scope of practice. And this is something that we're really keen to actually explore more within this webinar. And we're really privileged actually to be here at the invitation of the college, because I think it's such a great opportunity for us to talk about how these ideas and principles can integrate within your context. When we examine our role in supporting someone navigating distress, we need to consider both the profession scope of practice, which is sort of encompassing the full breadth of professional tasks and duties that could be considered as typically seen being within a physio's role, but also considering our individual scope of practice, which also kind of only occupies a smaller wedge of that professional scope of practice. And that's more dependent on someone's individual experience, their training, their competency, and the setting in which they work. So scope of practice, while from a regulatory perspective, there may be a more fixed professional scope of practice, individual scope of practice is really important to consider too, because that is really dependent on your own experience. Now in Australia, our scope of practice is quite different. We actually are working in a very different context where we don't actually have a scope of practice document that explicitly defines what we can and can't do. What we have is a code of conduct effectively, and from a scope of practice perspective, there aren't many firm limits on what we can't do. What we do need to be able to say, though, is that the tasks we undertake in our setting are justifiable, and that we are competent to carry them out based on various factors, so level of training, but also our settings and our safeguards that we're existing and working within. From a legislation and regulatory perspective, our context is very different. There aren't many restricted activities in Australia across allied health at all. Effectively, assuming that you're not trying to radiate someone, cut into someone, or prescribe medication, those are really the three big ones. Outside of that, there's very little that is, from a regulatory perspective, restricted. And I mention that because that is the context from which Ryan and I are coming from. And so throughout this presentation, we just really want to give opportunity, and we've tried to speak to the differences in your context as best we can, but we're really lucky to have Leanne here, and we're hoping that we can have further discussion about how these things might better integrate within your setting. So as it stands currently in Alberta, psychosocial intervention is a restricted activity. And specifically, the wording around that is that it's a restricted activity to perform a psychosocial intervention with an expectation of treating a substantial disorder of thought, mood, perception, orientation, or memory that grossly impairs judgment, behaviour, capacity to recognise reality, or the ability to meet ordinary demands of life. So that's really important to consider in this, and again, something that we'll keep coming back to. But what it really means is that a physio cannot treat or attempt to treat any sort of underlying depression, anxiety, or other psychological disorder that might have led somebody to thoughts of suicide. What it doesn't do, though, is prevent you from expressing concern or helping your patient to make sure that they can actually get the support they need from other professionals, which is a lot of what we're going to be talking about today. So before we move into the practical aspect of how we can navigate this in practice, I'm going to introduce you to Sarah. Now, Sarah's not a real client, but she is a amalgamation, I guess, of clients that we've kind of experienced, or encounters we've had in practice, that hopefully will represent probably experiences that you have a lot in day-to-day practice. And we're going to use her case to help illustrate the concepts that we introduced today and help you to see how they might look in practice. So Sarah's 35 years old. She works full-time as a grocery store employee, and she attends your clinic for the first time for her appointment for assessment of low back pain that she's had for the past 2 months after a lifting injury while packing shelves at work. Her pain's constant and interferes significantly with most of her day-to-day activities. She's tried to keep working immediately after her injury, but she had to stop after her symptoms were aggravated, and she's now not been at work for over 6 weeks. She lives at home with her husband, who's a self-employed builder, and 2 school-aged children, and is responsible for almost all of the household chores and caring responsibilities. Her goals are very much to return to work. She's very motivated to do so and to get rid of the pain. So you complete your initial assessment and you're satisfied that there's no indication of serious or specific spinal pathology. You know, we do all the expected things. We've reassured her about her prognosis. We have a discussion about what management options we can offer her. And maybe in that first session, we trial a bit of massage. You know, we give her a few basic home exercises, and we agree to catch up with her again next week. Now, if you're someone, you know, who works in a clinic with 20 to 30 minute appointments, you'd probably be pretty happy with that for a first appointment. And we're going to skip forward a week as well to when she returns to the clinic. And this is where we're going to start to unpack what we might start to see. So the following week, Sarah attends her appointment. And unfortunately, busy private practice, you're running a bit late. So she comes into the room, and when you start talking, she seems a bit frustrated and upset. And when you ask her how she got on after your last session, she says, "The massage helped a bit. My pain was less and I could move a bit better, but it only lasted a day or two. And before you ask, no, I didn't do my exercises. I'm just sick of the pain getting in the way of everything, and I'm starting to worry that it'll never go away. I can't keep putting up with this." So how do you respond? Because I'd imagine that most of us have probably heard something like this, probably many times over, and it can be really hard to know what to say. And in context, you know, we mentioned, you know, you might already be running behind. You might already be tired from a busy day in private practice. Maybe you might have thoughts of, oh, I don't really want to say anything that could make things worse. You might even have in the back of your head that if you start this conversation, you're not going to have enough time to review your exercises or do more hands-on treatment. Or you might be thinking, if I open this can of worms, I might be stuck and then I'll be running even more late. But what we're going to do is to start to talk through how we can approach this. And I'm going to hand back over to Ryan, who can help to integrate some of these principles in Sarah's case.
So I'd like to introduce you to the framework of risk communication. Risk communication views suicidal thoughts and behaviours as mainly a response to distress. Therefore, the principles can be applied to working with people experiencing distress as well as suicidal distress. The key principles are: be an active listener, be respectful, tread softly, be alert for distress, be calm, don't panic, easier said than done, use the evidence base, be skeptical of simplistic solutions, be humble, and be an educated educator. So I'd like to introduce you to the main concepts, which are first, do no harm, which we've just covered before, listen and engage, explore the person's unique experience. And within this stage, we'd be talking about suicide risk communication, asking specific questions about suicide, reinforce coping, and how to foster and facilitate connections. As Soph discussed earlier, a critical step for us is to do no harm. And we should already be doing this by making sure that we're trauma-informed in every single clinical encounter that we have to prevent that re-traumatization and minimizing distress. This should be a standard part of practice, as we do not know who has experienced potentially traumatic events and who may be experiencing ongoing trauma-related challenges. Therefore, we need to create an environment of safety in our clinical encounters that is collaborative. We need to prioritize autonomy and choice and facilitate empowerment. It is also critical we understand that ignoring disclosures of distress can be harmful by invalidating the person, decreasing safety and trust, and impeding access to appropriate supports. So, as part of this process, we need to listen and engage empathetically with our clients. The good news is that good physiotherapists already do this well. However, we need to make sure that we are not shutting down or avoiding conversations around distress or suicidal distress because we feel uncomfortable talking about it. While we are physiotherapists, not psychologists, we are humans and health professionals. They are sharing this with you for a reason, and you may not be the first, you may be the first or only person that they've been comfortable sharing their thoughts of suicide with.
So coming back to our question about how we respond, you know, as we mentioned, coming back to Sarah's case, we might have these sort of statements come from patients all of the time. Now, what I will say is that the scripts and examples of things that we share today, they're definitely not intended to be really rigid or prescriptive or too fixed. There are many different ways we could sort of probe and ask these questions, but what we are hoping to do is to give you ideas as to how that could look in the clinic setting. But honestly, the most important thing when it comes to these discussions is really just to be authentic and caring in our interactions. The exact wording of what we say often matters much less than somebody understanding that we are coming from a place of care and, you know, really meeting them where they're at. So these are here to help, but don't feel like, you know, it has to be word for word. It has to be something that fits with your natural way of communicating and the relationship that you have with the patient as well. So something we could say to Sarah in response to her earlier statement might be, I could imagine things must feel really frustrating for you at the moment. It must be really hard when your symptoms interfere so much with your usual activities. I really think it's only natural to worry about whether things would improve. I know I certainly would if I were in the same position. Would you mind telling me a little bit more about how you're feeling, given everything that's going on? And Sarah responds, it's just been really hard. I'm not sleeping because of how bad the pain is, and I'm laying awake stressing. There's a lot to worry about. My employer refused to report my injury, so I've had to use all my sick leave and my holidays. And since using all of that, I've been off work with no pay. If I can't get back to work, we might not be able to make our next mortgage payment. I feel guilty because I can't work or do things around the house or with the kids, and it's starting to cause fights between me and my husband. It's not his fault. He's pretty stressed too. I'm exhausted, but I just don't know what to do. I can't keep living like this, but I'm scared of doing anything to make things worse.
Now, we mentioned listening and engaging empathetically with our clients and the need to be attentive to invitations to ask about distress or respond to disclosures of distress. However, the next step is where many physiotherapists start to feel uncomfortable. We need to be willing to explore their distress further. While we're not aiming to diagnose a mental health condition or provide targeted psychological treatment, understanding a person's story is the best way that we can start working with them to identify the most appropriate way to help them manage their distress and connect them with supports. As Loza said, we must ask the patient and listen to his or her narrative to find suffering. One cannot assess suffering in a patient whom one does not know. There is no checklist approach to understanding and exploring a person's story of distress. However, invitations to ask about suicidal distress, including seemingly flippant comments and non-specific death wishes, should prompt you to ask directly about suicide. Ensuring someone who is thinking about suicide has the opportunity to be connected with appropriate supports is worth overcoming our own discomfort in asking. It is possible that exploring your client's experience of distress will lead to disclosures of feelings of thwarted belongingness and perceived burdensomeness. These are invitations to ask about suicide, and it is important to note that research has thoroughly debunked the myth that asking about suicide will put the idea in their head. In some situations, there may need to be the need to make a more immediate connection with a professional mental health supports. Things like fearlessness about death, elevated pain tolerance, access to means, histories of previous suicide attempts, and exposure to violence and death and impulsivity factors that increase someone's capability to actually die by suicide. Given the challenging nature of supporting someone at a more immediate risk and facilitating immediate support, collaboration should extend beyond the physiotherapist and the patient. For example, with assistance from colleagues and supervisors, more formal mental health teams where available. This is necessary as clinician anxiety can impede problem solving.
And I just want to build on what Ryan has just mentioned too. So, you know, those things are true even in our context where we don't have as restrictive scope of practice legislation. And that still holds even for us. So, you know, we are recognizing even where we may not have a specific scope of practice restriction that we are not psychologists. And if people are presenting with suicidal ideation and planning, that there is a need for more specialized and formal support, which we'll go into a little bit later too. But in your setting, because there is likely to be potentially a greater restriction on how much you can explore with that person, that it's likely that you will want to be engaging even sooner potentially in your context and sort of erring more on the side of getting people involved. So I just wanted to emphasize that. But if we bring it back to Sarah, so already by sort of listening out for that invitation to ask, we've sort of already asked her to tell us a bit more about her experience. We've sort of engaged with her and we've explored her story. We are starting to think, you know, okay, so there is evidence of some heightened distress there, and we're starting to think, okay, we really need to get a better sense of what's happening here and maybe ask some additional clarifying questions. But this is where we can maybe think about the ways in which we do that. So what about, you know, using some screening tools, maybe the PHQ or the DAS-21. This might be something that actually comes through in discussion, because I'd be interested to see if these are tools that are used routinely in your setting as well. But I know particularly in our setting, the PHQ less commonly, but the DAS21 is definitely something that gets used a lot here in Australia by physiotherapists. It's fairly standard. So I'm not sure if that's different at all. But we can kind of consider the role of questionnaires. So questionnaires can be used to help assist case formulation. So we've mentioned the DAS21 already. There are a few other scales that are often used to get a sense of other psychological distress, so the impact of event scale. Most of you are probably familiar or may even use the Cerebro musculoskeletal pain questionnaire fairly routinely. And the PHQ2 and 9 are also one versions that are available. They can be really useful, and I think they're valuable, particularly where clinicians may not feel as confident, or if they feel they need a little bit more support or structure to be able to ask these questions, which is why they're fantastic. Ryan and I were sort of discussing this before the presentation, and actually Ryan and I probably don't use questionnaires that much in our practice, primarily because we feel comfortable sort of exploring and asking the questions in a more free-form format. But particularly where people may be less confident, or if, you know, particularly from a regulatory perspective, again, this would be something that would be great to get Leanne's take on towards the end of the session, but whether or not having sort of an established questionnaire that includes these questions might help to better make sure we're sort of sitting within scope of practice. But we need to remember that any use of screening tools and questionnaires is always going to give us a very limited two-dimensional view or one-dimensional view of someone's experience, and we can't just use them as the be-all end-all to try and classify people as high or low risk and to be really deterministic about what care they need. And when we classify or label people as high or low risk, or try to stratify care based only on that, what we're risking is that there's this real rigidity around care, and we can actually, you know, risk compromising that person's autonomy, because people may present very, you know, what we would deem low risk based on these scores, but they might still actually really benefit from or really want additional support. And if we're not willing to explore that, those are these missed opportunities. And we talk a bit about the issues with risk stratification a bit on later on too. The PHQ2 in particular can be really useful, and it's a really simple two-question item which can be integrated really nicely in practice. So it's research often recommends asking the first two questions of the PHQ2, and if there is a positive result on those, to then proceed to asking additional questions. And the good thing about the PHQ2 and then progressing to the 9 is that it actually does have a question about suicidal ideation. So down the bottom there, question I, you'll see there's a question that relates to thoughts that you would be better off dead or of harming yourself in some way. So it can be a nice way to integrate this. So, you know, and something that you may not, particularly for those first two screening questions, you could introduce it as part of your actual questioning and your history taking, as opposed to having it be a form. So can be quite useful. And most of you are probably familiar with the DAS21 that gives us a bit more of a metric as to how much distress someone might be experiencing along the lines of depression, anxiety, and stress symptoms. So there's a few options out there, and figuring out what works in your clinical practice is worth having a think of, as well as how it aligns with the other settings in which you work, but also within scope of practice considerations too. So I would tend to ask Sarah something like, after she's disclosed that she is having, you know, there's elevated distress. I mentioned I probably wouldn't tend to go to questionnaires, but what I would tend to say is something along the lines of, thank you for sharing this with me. It sounds as though things are really challenging at the moment. It's actually common that people experiencing physical or emotional pain might start to have thoughts of self-harm or suicide as a way to manage or stop their pain. Is that something that you've experienced? Now, we need to make sure that we're asking directly. By asking directly about suicide, we're normalising it, and by not beating around the bush, we're actually modelling safety and disclosure. So if somebody is working with a clinician who beats around the bush and they seem apprehensive to ask, or maybe they're avoiding using the word suicide and being a bit vague about it, it creates this sense that suicide is actually a bit of a taboo subject or something to be a bit afraid of. So by being really direct and not being afraid to talk about it, it helps to model that safety and disclosure and encourages them to to disclose. Now, Sarah could give us many different responses here. So the first and probably the more common that we might hear might sound something like this. Oh, no, I could never do that. I do sometimes think I'd rather not be here, or that it would be easier if I were dead, so I wouldn't have to deal with all of this. But I've never made plans or anything. I'd never actually do it. I couldn't do it to my kids. Okay. A response like this is good because there's evidence in there. She's already telling us that there's no plans, there's no intent there, and she's also highlighting that there's significant safety factors. The fact that she's mentioned her kids, that gives us really helpful information in sort of working out how much support that she's likely to need. But we might not always get as reassuring an answer. So an answer that is a bit different, where we might need to do a little bit more investigating, could be something like, yeah, I have thought about it. The pain just feels too much sometimes. And it's like, I can't see a way out. Those thoughts do sneak in. They come in more when the pain's really bad, like it just won't stop. And I feel so alone in dealing with it. I haven't told anyone because I don't want them to think of me differently or to put it on them.
So when hearing people disclose feelings of distress and thoughts of suicide, it is tempting to either jump in and try to fix the person's problems, or if too overwhelming, ignoring it altogether. However, both approaches have quite serious issues. So, issues with ignoring signs of suicidal distress, including the person feeling dismissed, invalidated, stigmatized, and isolated. And it is a missed opportunity to support someone experiencing significant distress find help. For the clinician, feelings of guilt, regret, shame may also emerge by feeling that they did not respond appropriately. On the other end of the helping continuum, an issue with paternalistic problem solving includes ineffective support, as the management is often not patient-centered and can leave the client feeling disempowered or increase their dependency on the clinician. For the clinician, this can potentially result into increased personal distress, compassion fatigue, and burnout as a result of over-empathizing and taking on additional support work that might be beyond their scope of practice. So while a comprehensive suicide risk assessment is likely beyond your skill set unless you've completed much suicide prevention training, identifying and recording the following information is useful and can inform a mental health professional determine what the next steps are. However, a mental health crisis line or ED could also support you in asking these questions, so don't feel like you have to do this alone. So, in the event that someone discloses an actionable plan, physiotherapists in the public health system should also seek support from their attending medical officer or a mental health professional trained in suicide risk assessment. Physiotherapists work in the community, such as private practice, should contact their region's mental health crisis line or emergency department for support if no appropriate mental health professional is available locally. In situations where there is clinicians and help seekers' best interests to get another health professional involved, the client should be involved in the process and ideally provide their consent. However, in some situations, the physiotherapist may decide to contact emergency health professional or emergency health service without consent if the client is likely to harm themselves or others. The decision to seek additional immediate support should be explained to the client as a way to help them cope rather than to protect them from suicide.
So Ryan sort of touched on it in a sense, but it is really important to note that while there is a lot of research out there that sort of talks about suicide prevention from a risk assessment perspective, there is some research that has actually shown that classification based on perceived risk is actually largely ineffective, and it doesn't really predict those who will go on to die by suicide. So as little as 5% of people who are high risk will die by suicide, which is pretty similar to those considered to be within the lower risk groups. So given how difficult it is to predict who might attempt suicide and who won't, there are those who argue that we really should not be trying to classify and really sort of standardize our approach, and we need to instead focus on providing individualized, compassionate care for everyone and work collaboratively with them so that we can help co-create a plan for them to cope and to establish their needs. And Ryan's going to talk us through what that looks like in a sec. So bringing it back to Sarah, before I hand back over to Ryan, Ryan, we had a slide earlier talking about the different elements of questions that we might ask to try and get details as to what's going on. So if we were to, we asked Sarah, you know, have you ever thought about or tried to harm yourself, or have you ever thought about how you would harm yourself? And in Sarah's case, she tells us that she has had previous instances of vague suicidal ideation similar to what she's experiencing now, but she hasn't necessarily progressed to having any real intent or formed plans or thought about specifics of how she might harm herself, which is good. You know, that's sort of more sitting within that sort of passive ideation rather than thinking that, you know, she's potentially someone who's more at acute risk of harm. If somebody did say, yes, I have sort of specifically thought about harming myself, we'd obviously want to get more detail about whether what they had considered in terms of means, and we want to know and consider, you know, are these means that they have access to, because that would heighten risk as well. But we'd also probably want to consider and ask whether they have access to any other lethal means. So things like, you know, consider things like medication that they could overdose, or, you know, firearms as well. And if somebody had said that they had thought about how they would harm themselves, we'd also want to get a real sense of whether that they've actually created any specific plans or thought about timelines. So to really help us nut out how is this situation and how acute is that risk.
And before we go into reinforcing coping, the other things that we'd also want to consider, and this doesn't apply to Sarah's case, but is intoxication, because that can also preclude a valid immediate assessment. Also, the safety of the person, thinking about others that could be involved. So is there a risk of, you know, again, I'd hate to think about it, and it's very uncommon, but a murder-suicide? Are there issues with custody of children or other financials going on? And is there any evidence of like postnatal depression and things like mental health conditions that are also complicating assessment? So once you've gone through and listened and engaged with the person, explore their experience, and then ask those questions directly about suicidality. And you don't have to ask every single one of those questions, but it is a bit of a flow. If someone does have plans, you then ask about means and go from there. The next step, no matter what those responses are, is to put together a strengths-based collaborative plan used to identify the patient's existing strengths that they may currently and coping mechanisms that they have currently have available to them, or they have previously used to cope with their distress. And the aim of this is to encourage helpful coping. In an attempt to self-regulate or escape overwhelming distress, a person may engage in a series of coping mechanisms which could be helpful or unhelpful. Physiotherapists should ask permission to initiate this step rather than jumping into problem solving. Where possible, aim to reinforce the person's existing strengths and coping strategies. While the goal is to reinforce and facilitate healthy coping, it's important not to force the cessation of unhealthy coping strategies without a plan to replace them with positive ones or helpful ones. Taking away an unhealthy coping strategy without replacing it with a healthy one can actually decrease a person's ability to cope in that moment. So, rather than focusing on risk, I think it's important to highlight that evidence-based suicide prevention is focused also on considering coping needs. Storman's coping planning approach to suicide prevention argues that support to cope should be provided to everyone experiencing distress who asks for assistance, rather than focusing only on people who disclose plans for suicide that would typically be identified as high risk. So rather than thinking about low, medium, and high risk, also consider whether the person in front of you has low, moderate, or high support needs. So on the screen are some examples of healthy coping strategies. However, while listening to music may help you, for some people it does very little. The point is to reinforce existing healthy coping strategies that work for that person. Sometimes people in distress forget what has helped them in the past, and they just need a gentle reminder or a discussion about it. For those of you familiar with the noise group DIMS and SIMS in the context of pain management, you might actually see some overlap. We just need to acknowledge the dual role that they may serve and give ourselves permission to explore them with patients experiencing distress and suicidal distress.
And from a clinical perspective, bringing it back to Sarah, there are many different ways we can kind of try to draw out what someone's existing strategies are. So, for example, we could ask Sarah something like, we all have our own ways of coping with difficult emotions. What strategies are you using to manage at the moment? Or we could ask her, what are some things that have helped you to cope in the past? And we'd also want to get a sense of not just the strategies that she's got, but also what supports there are. So Sarah had mentioned that she hadn't really told anyone about how she was feeling because she didn't want to put it on them. So I would want to sort of explore that a little bit more to try and establish who that network could be or has been in the past, and say, you know, is there anyone in your life that you might feel comfortable talking to? Or is there anyone that you've spoken to in the past when these feelings have come up? So given that she's had previous suicidal ideation, I would be asking her, you know, around that time, had she previously seen a psychologist or a counsellor or spoken to anyone else? Or even in her case, if people have engaged with formal support in the past, they may already have an existing safety plan or coping plan in place that they can kind of draw from previous experiences. But we can also get a sense of whether there's maybe more informal supports in her network that could, you know, be helped to bolster her coping as well. So we asked these questions, and after chatting with Sarah, this is what she shares with us. So she talks through that the way she's currently coping at the moment. She's using endone as prescribed by her GP. Not sure if there's any regional differences here. Endone is oxycodone. I'm not sure if that's the same there for you guys. But she also mentioned that she's having 2 or 3 glasses of wine before bed because she was having a lot of trouble sleeping, and she finds it relaxes her. She does take hot baths because that helps soothe some of her pain. She mentioned she's trying to distract herself a lot, so lots of social media and watching Netflix as best she can. And she does text a friend generally, not about how she's feeling, but she generally tries to keep herself busy with conversations. But when we asked her about strategies that she's used in the past, she flagged that, you know, she's found generally going for a walk can help her feel a bit better. Things that make her feel good, things like cooking and baking with the kids or listening to music and singing. She does like going out for a coffee with her friends or with her family. But she also mentioned from her previous experiences when she had issues with suicidal ideation in the past that she had seen a psychologist. And so she shared that she had a few strategies from that she'd used. So the Headspace app, which has, you know, mindfulness meditation type exercises built in. She did in this case have a previous safety plan. And that when she had seen a psychologist in the past, that had been helpful, though she hasn't re-engaged with them yet. So I'm just going to emphasize what Ryan mentioned before and highlight that, you know, if we look at some of these early strategies, the endone use and 2 to 3 glasses of wine before bed, from my context coming from a pain management background, I know sometimes like our brain sometimes can orient straight to these things and think, oh, that's maybe an unhelpful coping strategy. And there can be a tendency for us to want to try and jump in and stop that, even if, you know, prescribing and that sort of broader management isn't necessarily our role, but as a pain management approach generally, there might be a tendency to do that. But in the context of pain, you know, particularly there can be a focus on reducing opioids. But if we take these away before Sarah is able to buffer with some of her other strategies, we do run the risk of increasing distress. And in our context here in Australia, in the last sort of 5-10 years, there's been a real shift towards opioid deprescribing, and we've actually seen that in the wake of that, there has actually been an increase in distress and suicide attempts when people haven't been able to access opioids to help them manage their pain. So something I mentioned, because while we might not be directly responsible for managing that, we need to be aware of it in the context of that person's overall care and, you know, consider that could be something that could impact on distress. But what we could focus more on is the strategies that Sarah's already used previously in the past, but she's not already currently using. So there might be some barriers to these at the moment. For example, walking or cooking might be limited by her physical symptoms, but hopefully you would be hearing this and seeing that there's opportunity not just for us to elicit coping, but we have an opportunity to really integrate that with our movement and our management, which is kind of what we'd be wanting to do for back pain anyway.
So while supporting people experiencing distress is within the scope of physiotherapists, and again, there's nuance around what the term support means, we should not attempt to do this alone, because that's when we're going to find ourselves outside of our scope of practice. And we should not ever disregard the need for special support, particularly when there are suicidal thoughts and behaviours emerging. So professional and social connections are really important protective factors against distress and suicide. Informal supports include things like clients, family, friends, and formal supports might include things like their GP or their psychologist. And there are other supports, as we've mentioned before, like emergency services and helplines. Here are also some examples and supports that may be available to you in your area, but I won't stay on this slide too long because the college has articles on suicide prevention, and so please refer to there for further details that are relevant to your geographic region. So returning to the concept of breaching confidentiality, there is currently no positive duty to report. However, under privacy laws, you may breach confidentiality for the purpose of alerting appropriate authorities, which may include a family member or guardian, the patient's family doctor, or another healthcare provider involved in the patient's care, or a local police authority under certain circumstances. And these certain circumstances are that you perceive that there's a clear risk of harm to the patient or another individual, the danger poses a risk of serious bodily harm or death, and the danger is imminent. But the important thing to consider with imminency is that this does not mean that the action must be occurring immediately. It may refer to a future risk that is serious enough that a reasonable person would believe that the harm would actually be carried out.
So, we're probably feeling like, from what Sarah has told us, that she would benefit from additional formal support, particularly because she has seen a psychologist in the past and found that helpful. But this isn't about us jumping in and saying, well, it sounds like you need to go back to your psychologist. We need to really try and maintain that autonomy and choice and make sure that we're working collaboratively. And just keep in the back of our minds that for many people, healthcare professionals have been a source of distress in the past. And the act of actually engaging with someone new, particularly if people haven't seen a psychologist in the past, can be really confronting. And in some cases, it can actually be harmful. So we don't want to, sort of, I guess, underplay some of those more negative experiences that people might have had. And particularly if you're like me and you're working with people who maybe experience chronic pain, for many people with chronic pain, they might even have experiences of being explicitly or implicitly told that their pain is psychological or in their head. So we do have to be really delicate about how we sort of broach the need for potential support and how we engage with them. But we can still acknowledge our own professional boundaries. And while someone might choose not to engage in an additional support, particularly in Sarah's case, where she wouldn't meet that threshold for, breaching confidentiality because, there wouldn't be that imminent risk. It wouldn't be a suitable situation for us to do that. It really comes down to her autonomy and her choice to engage in additional support. So in those cases, we just need to be really honest and transparent in that. And we need to be really clear about where our own boundaries are and what we can and can't do in supporting that person. But one way we could kind of open a discussion about whether the person feels like they need additional support is by asking them something like, do you feel as though you have enough support to cope and feel safe at the moment? If not, would you like to talk more about the different options available and find something that feels right for you? And in her case specifically, I'd be asking whether or not she might be open to re-engaging with the psychologist from the past. And just to highlight too, that even in situations where somebody might have been at more imminent risk and we could technically, meet that condition for disclosure, we really, even in situations where that is the case, that's really an absolute last resort. And even where we could, we would avoid it at all costs. So we would still be looking to try and do that collaboratively. And really using that sort of disclosure against consent as an absolute last resort. Ryan and I were speaking about this before, and between us, we've only had 2 situations between us where we've had to really do that. So, it should be limited, and we should be able to try and preserve that autonomy as best we can, even in those situations where there's more imminent risk. And so around this, just to cap off, we're going to run through just where Sarah got to in terms of her coping plan. And now these are not in any specific order and not necessarily in the order we would have done them in session, but I've structured these this way to give you an idea of the things that as a physio we might already be doing in practice, but seeing how these actually fit within that coping plan. So these are not necessarily chronologically in order, but to give you an idea. So at the end of the session with Sarah, We might have decided, and there's certainly no one right way, but based on what Sarah's told us, we could consider, instead of providing exercises along the lines of what we'd previously done, we could suggest that we change the focus to initiating a gentle walking program as tolerated, and give her all the education about appropriate pacing and reassurance that we usually would. You know, we're still getting her moving, we're still modifying activity. That's absolutely within the physio wheelhouse, but because going for a walk has been part of her previous coping strategies, it's doing double duty. She mentioned that cooking with the kids has been something that has really helped her in the past, and activity modification is absolutely something we do as physio. So can we give her options to enable engagement? You know, maybe we can get her to take breaks throughout, or sit down while she's prepping, or modify it in other physical ways that enable her participation in these things. She mentioned the Headspace app, so you know, we can encourage her to start using that app again, you know, particularly in the evening before bed, because that's when she's, you know, having issues with getting to sleep. And you know, Sarah might suggest, or based on these discussions, that maybe she could arrange to meet her friend in person for a coffee, or go sit in the local park with her husband and kids on the weekend. And she could also you could have a discussion about whether she's comfortable to discuss how she's feeling more with her husband. And in Sarah's case, even though we know she's not at that more acute risk, you know, one of the things we could do is support Sarah to book an appointment with her GP that afternoon if she can get in. So that could be you helping Sarah, like facilitating a phone call in session. Depending on the situation, you know, if the person, you know, you're pretty comfortable that the person would be comfortable to do that themselves and there's no barriers to that, then it might be okay for them to do that out of session. But things like just even writing a really simple letter for them to take to the GP that just sort of outlines really briefly that this is something that came up in a session and we'd appreciate your support to facilitate additional support, can be a really great way to help bridge that gap and facilitate additional support. But what I would also be doing in those situations is to give somebody contacts for the mental health support, like the crisis lines or other resources, that if she did feel like she needed more urgent support, she has those available to her.
So if you take one thing away from this presentation, is that you do not need to be a mental health professional to care and attend to clients experiencing suicidal distress. While physiotherapists should not pretend or attempt to replace psychologists, dividing physical and mental health support into physical and mental health sectors means that there are a lot of individuals who fall through the cracks. And the important thing is that we as physiotherapists can play an important role here as a touch point and connector for those who are falling through those cracks.
So in bringing it back to you guys and your preparation, you know, how can you be prepared and what can you do? The first thing I would say is just keep that potential for people experiencing suicidal distress on your radar and be ready to ask the questions and to help facilitate that. The more prepared you are going in, the easier it's going to be, you know, when it does come up. Make sure you have those resources and those processes in place and have the services and resources readily available. In our clinic, I've just had a physio who started work with me, and we actually put together a mental health policy where we have a really quick, ready access of like, yep, if somebody, you know, if you do need help during a session or, you know, somebody needs resources, here's the list ready to go. It's so much easier when it's there and readily available. So really consider having something like that in your setting. And, you know, having like, whether it's called the workplace mental health or suicide first aid plan or a mental health policy, whatever it is, you know, have those national services and links there, but also think about the logistics specific to your setting. So for example, if you did have a disclosure and we don't want to leave someone alone, how would you actually go about notifying your support team, for example? You know, how would you potentially communicate with admin around reorganizing your day? Just the logistics, because every setting is very different. So making sure you've thought it through in your setting and knowing what's available to you and how to tackle it's good. And finally, I think just actually discussing suicide as a team and getting that reassurance that actually managing and sort of attending to the risk of suicidal ideation is actually a priority. If there's a culture in your team that, yes, this is sort of part of something that we should be attentive to so that we can support that care, that makes a huge difference, particularly if we're talking about time-poor private practice settings where there might already be a pressure to kind of, you know, not really engage because it's a busy day and you know, financially, you know, unfortunately there is that pressure of feeling like you've got to, you know, just push through and get through your day. So if the team can have a discussion and sort of accept that, yep, this is a priority for us, then that can help us feel more prepared and more confident that we can actually, start to help support someone through that. And making sure we've got options for clinician debriefing and support as well. But we do recognise that training in mental health and crisis prevention is needed. We know that physios are already exposed to clients who are experiencing distress, both suicidal and non-suicidal distress, and we know that generally physios feel unprepared to manage these situations, and this can be a contributor to burnout. One of the objections, I guess, to including this content in physio training is that the curricula is already too full. And it always is a balance with that. What we would say is, if there's anyone here in the audience who is involved in education and training, to really consider whether or not some of these principles can be embedded in your training for the benefit of physios, but clients as well. And we would love to speak to anyone who's interested in working more in this space, because it's something that both Ryan and I are pretty passionate about. So we're going to end our formal presentation there. There's a few bibliography slides there, but I'm just going to, I guess, finish off with this quote before we launch into questions. It's really like this quote by Norman. For those who have been grappling with dark thoughts and a loss of hope, a concerned clinician who frames the question openly, who appears to genuinely want to know the answer and work together to come up with a plan for safety-seeking behaviour, that could make all the difference. And I think that really encapsulates pretty much everything we're trying to say here. So thank you very much, everyone, for listening to the presentation. We're very happy. I know timing might be a bit tight and people might have to go, but Ryan and I are both happy to hang around for discussion and questions. Thank you very much.
Well, thank you very much, Sophie and Ryan. That was an excellent presentation. I'll offer my perspective while the audience has a chance to type in their questions. I want to offer my perspective on what you said about the how to manage the situation, because one of the things that happens at a college level, not frequently, certainly I would never want to say it was a frequent question, but it's perhaps one of the most urgent questions I've ever faced as a practice advisor is the question of, I receive a call from a clinician who's very distressed because they have a patient in clinic who has just disclosed suicidal ideation, and the clinician has no idea what to do. What do I do? What do I say? How do I proceed? So I think having some tools in the toolkit, some policies in place can really make a huge difference for having the ability to respond in an appropriate manner and in a manner that's supportive and ultimately successful, hopefully, for the client. And so I'm going to come to a question to you, Ryan, in a minute about tips for staying calm. I'll put that out there so you can start to ponder it. But I do want to just briefly touch on the scope of practice question and the privacy question from a college point of view. So, when it comes to the scope of practice question, that is one of the key questions that we face as a college. And I think it's important to reinforce there is no standard of practice and there's no legislation that prevents a physiotherapist from taking a psychologically informed approach to physiotherapy, which is a lot of what you're talking about here today from my lens, from my perspective. We're not talking about trying to treat a disorder of mood or thought. Oh, I love that slide. Thank you for putting that up. We're not talking about trying to treat a major depression, but taking a biopsychosocial informed approach to care is absolutely something that physiotherapists do, and it's something we would support. There's also no rule that would prevent a physiotherapist from identifying a concern that's outside either their individual skills or the scope of practice of the profession and making appropriate referral onwards. So, that ability to screen and say, hey, there's a problem here, and I'm not the person to address it, but I've identified it. I think that's really important. And indeed, there are standards, the communication standard, the concurrent care standard, that really do call upon and establish requirements for physiotherapists to do exactly that. And I obviously you have a different perspective on the definition of scope of practice than I do. When I look at the HPA scope of practice description of what a physiotherapist does, I see it as being quite broad, actually. So it's interesting. I mean, we all have our different perspectives on this. I think back to the days when we had very narrow and specific definitions of scope. I do see the HPA, the Health Professions Act, as being quite broad, with the exception of those things that are restricted activities under the Act. And there's a reason they're restricted activities. We don't want people doing surgery if they haven't got training. We don't want people doing dry needling if they don't have training. This is no different. So we need to have an appropriate respect for the expertise of others as well. So that's what I have to say about scope. and I could talk about it for a long time, but I won't belabor the point. When it comes to privacy, you know, that the three-step test that you shared on slide 61 a moment ago, I think it's really, you said it, but I'll reinforce it, really important to remember that when you can garner agreement for disclosure, it's always going to be the best case scenario. You don't want to jump to that. It is serious business to breach a client's confidentiality. It's going to damage the therapeutic relationship. So you don't want to do that unless you really feel like there's a strong concern or strong reason to do so. And there may be times when there's a strong concern and you need to do so, but you just want to, if you can avoid it, you want to avoid it, obviously. You know, there is an ethical question there between, and a balance to be struck between, do you do what's in the client's interest and beneficence and that value, or do you honor their confidentiality and their autonomy? And I think you highlighted that really nicely. So I wanted to say those things. And I will come to my question now, but I do see we have a couple of other questions in the audience. So Brian, what are the tips for managing your own distress? Going back to my original comment, you have somebody who makes this disclosure to you, and I mean, my reaction is, I'm not trained. What do I say? How do you manage to keep calm in that? It's easy to say and hard to do.
I'll give an example of one actually that happened. I received disclosure a week ago on a very complicated situation. And it actually got to the stage of not necessarily breaching confidentiality, but the collaborative plan, we were really struggling to put that together because the person had been previously to one of the mental health services in the region that I would normally refer to and had had a very poor experience, so was not interested in going there. He did actually have plans and means and some of those things that were building up the level of immediate risk. However, the issue with that, it was that he wasn't going to act on that. He was comfortable enough for a period of time for the next week. It was actually after that period of time that he said he would probably struggle to keep going without support. So we were trying to navigate a plan of where this would work, and he was between the public and the private system. And I was finding it incredibly stressful. And we got to the stage where we worked out a short, immediate 24-hour plan. And that involved me doing certain steps and involved him doing certain steps to seek support. And then we regrouped that 24 hours later. But in that period, after we had that kind of intermediate plan, I used our local public, even the service that he preferred not to go to. He was happy, gave me the consent to talk to them and go, this is what his situation is. What services do you have available? What services do you know about? And being able to talk through that process with a mental health professional meant that if something did go horribly wrong, that I actually was a bit protected personally, but also I felt more comfortable in my decision. So that's one thing that you can do, and helplines will do that. I've received calls from psychologists who actually have the patient in front of them, and they're just trying to bridge that connection between what the supports are going to be for that patient and themselves. And then I've received calls when I was at Lifeline from other types of health professionals just seeking advice and guidance around what they could do in a situation. So reaching out is a main one. Manage those feelings.
The other thing I would add to that as well, sorry to jump in, Ryan, did you want to finish? Was there an end of the...
That works. That's an end of the thought.
Cool. Sorry, hate Zoom for that. The other thing that I just mentioned is just like kind of coming back to that final slide is just be as prepared as you can be. You know, have the resources, know what the supports are, know who you can contact, because you don't want to be in that situation where you're confronted and then suddenly, you know, I don't think we mentioned it specifically in this webinar, but we often, as part of these webinars, use the phrase, you know, distressed minds don't problem solve very well. And we say that for patients, you know, but also it's equal for the clinician who gets confronted with this out of left field and goes, oh my God, like, what do I do? We don't want that to be the moment where we're trying to, you know, get all of our resources and to figure out where to send people. So really recommend that you just, you know, have a bit of a game plan beforehand, you know, have resources in a file or a PDF, or I've had clinicians who have had little like sticky notes. Sometimes you can get little like crisis cards made up that actually have support services written that, you know, you can even give to patients sometimes. You know, those sorts of things, just have them readily available so that when it does happen, it's never going to negate that sort of gut sink feeling that you can get when you have a disclosure, but at least you can kind of know if you've got a next step. If you know, okay, I have this file, and then that's going to help prompt me through. That takes a lot of the stress out of it. So yeah, that would be the other thing I'd add.
And that's would be a good segue, and I don't want to you probably were going to do this, Leanne, but there were a couple of questions around documentation from Alison and me. And I think with many of these stages, if you prepare in advance, then potentially the health service or the private practice, again, the private practice may not have one, so you might have to develop your own. But thinking about what questions that you might ask, and so if you might come back to that earlier slide around the New South Wales suicide risk assessment, because these are the questions that I actually document. Like even on my physio, if I've asked these questions and I've received a response, I'm writing this down. This is a medico-legal note, and then I'm putting in my plan clearly what the next steps are. So even though it is a physio note, I will document all of that. If there are things that are a bit, particularly in a public setting, that might require the note to have restricted access, I document first and then would talk to the team that manages the electronic medical records to put a potential lock or something on that for certain individuals. But
it
yeah,
might also be, and you might have a bit of insight on this too, but I know like something that would be going through my mind too is our documentation is also part of protecting ourselves as well. And so the last thing we would want is to have, like, God forbid something did happen and there would be an inquest or something like that. The last thing that you want is, you know, it does get investigated. Who is this person seen? And you would want your notes to really clearly reflect that, yes, if someone did sort of disclose this, that you had done your duty in exploring that, trying to help facilitate support. I actually think that that is a much safer option than sort of not documenting, because we're not diagnosing anything in that. It's really just about assessing what is that person's situation, support, and how can we facilitate that additional support and safety. I don't know, Leanne, maybe you've got some insight on that as well.
Yeah, I would point to the standards of practice in Alberta that talk about the importance of documenting any communication with or about a client. So if you're having this conversation, it does need to be documented. I would say it's important to be as clear, as factual, and as accurate as you can be. So, you know, you want to avoid judging language, you want to avoid euphemisms, you want to really get to the facts. And, you know, if you have objective things that you've done like the DAS or the PHQ, obviously you're going to be documenting that because it's part of your documentation. You know, Ryan, you raised the matter of shielding content. There are, certainly with private practice environments where you use electronic medical records, there are access-based controls that you can put in place. I'm certainly not an expert on that, but I do know they exist so that you can limit who has the access to the client record. Those are things that people should have in place anyways. You know, your admin staff doesn't typically need to read everybody's detailed medical history. So those do exist, and I would encourage you to look at that. In the public sector, you know, there are mechanisms in place, and I'm not able to speak to that. But again, someone in the public sector would have access to privacy officers who'd be able to speak to that, and health records departments that would be able to help navigate that situation. But as you say, Sophie, you don't want to not document something like this. It does need to be documented, and you know, it's protection for the client, it's communication to other health professionals, it's protection for the provider, it's all of the above, and it's really essential documentation.
Absolutely.
All right. So I don't see any additional questions coming in at this time. So I think we will end today's presentation. I want to thank Sophie and Ryan again. It was an excellent session, and it will be a lasting resource for our registrants. And I really look forward to speaking with all of you in the future. And thank you again, Sophie and Ryan, for an excellent presentation. So everyone, have a good evening, and thank you very much.
Thanks, everyone. Thanks for having us.
Thanks for having us.
Bye.
Bye.